he had from Robert Wood Johnson and got an AOA there, and did internal medicine residency at Sinai, and is now a cardiology fellow at Sinai. He has some phenomenal work already. He's published over 10 papers, many of them on cardiogenic shock, which is his main interest. And he has served on several medical education, new age medical education, social media type stuff. Cardio Nerds is one example, and so on. So without further ado, I am going to ask Jason to present some of the highlights. So many of you know that the American College of Cardiology 2023 meeting just concluded last month. And this year, actually, Mount Sinai starred in many of the late-breaking clinical trials. So Jason is going to highlight some of those.
Thank you, Dr. Goodwani, for your kind introduction, for your invitation. For those of you I haven't met or had the pleasure of working with previously, my name is Jason Feynman. I'm one of the second-year general cardiology fellows, and I have the distinct honor and privilege presenting this week's Institute for Critical Care Medicine Grand Rounds on ACC 2023 wrap-up. We're going to go fairly fast in the interest of time, kind of covering the highlighted late-breaking clinical trials and some of just the clinical applications from them, and kind of questions about further research. Unsurprisingly, I have no relevant financial disclosures. So our objectives for today, we'll discuss and analyze the results from the major late-breaking clinical trials presented at ACC this past year, just earlier in March, and then discuss some of the potential clinical impacts of presented research. And we'll go over any questions at the end that you might have. Just in the interest of time, we'll save them till then. And after I present some of these, we're going to talk about two other projects, one that I had the opportunity to present there, and one that some fantastic individuals here at Mount Sinai, Adam, who's one of our medical students, and Sophia Golek, who's now one of our third-year internal medicine residents, also presented there and did with the critical care department. Divided kind of the late-breaking clinical trials into three main perspectives. One is in the field of interventional cardiology, one is in the field that I'm calling risk factor modification, and one is in the field of what we're going to call as vascular medicine, also thrombosis as well. Within interventional cardiology, but there are really 5 trials that really are going to change the landscape within ACC that were presented this year. One of them is the Triluminate study. Next was BIOVASC, Yellow 3, the COAPT 5-year outcomes, and then the low-risk TAVR 3-year outcomes. Let's go into it from the start, and we'll talk a little bit about Triluminate. So what was the Triluminate study itself? So we know that based upon ESC guidelines, tricuspid regurgitation surgery is recommended as a class 1 indication for symptomatic patients without right ventricular dysfunction. It's also indicated at the time of left ventricular valvular surgery from the ACC-AHA guidelines. However, these surgeries do have fairly high morbidity and mortality, unsurprisingly, possibly as a result of liver dysfunction that accompanies significant TR. That being said, some new devices have come about to handle tricuspid regurgitation from a transcatheter approach. So this was a multinational randomized, non-blinded study randomizing adults with severe symptomatic tricuspid regurgitation. They could not have severe pulmonary hypertension. They had to have a PASP of less than 70 millimeters of mercury, no other conditions needing urgent surgical or interventional corrections, and receiving stable doses of guideline-directed medical therapy, most commonly diuretics for right ventricular dysfunction, who are at least intermediate or greater surgical risk, randomized to tricuspid valve intervention with TriClip versus continued medical therapy. And this is 1-year outcomes, which is a hierarchical composite, which we'll talk about in a second, of death of tricuspid valve surgery, heart failure hospitalization, and improved KCCQ scores. Just for ease of kind of explanation now, the way that these hierarchical composites work is that they match up individuals in the intervention and the control group 1-to-1 and say whether or not the control group was better or whether or not the interventional group was better. So in this, there were 350 patients, 175 in each arms. You would match up all 175 patients with the other 175 and see just for each of these individual outcomes who won, essentially. Did the tricuspid intervention win, or did the control win? If it's a tie, you moved on to the second in their hierarchical outcome. If they won, that's it. We say that one of them is better than the other one. So 300 and 50 patients, 175 in each arm. The average age is 78 years old. 55% of them are women. 51% of them have torrential TR, which is the highest grade of tricuspid regurgitation that we use in this study. 37% have had prior left-sided valve intervention. Most of them had fairly preserved ejection fractions with an AF of 59%, and this was 1 year follow-up. So at 1 year, you can see that the hierarchical outcome, we've got 11,348 wins for tricuspid valve intervention, 7,643 for control, and ties in 11,634. Again, like I said, this is comparing all 175 patients in one arm to all 175 patients in the other arm. At the end, there were more wins for tricuspid valve intervention we see than control, meaning that it is the winner here. You can see that this is primarily driven, though, due to changes in KCCQ score. It's not difference in all-cause mortality. It was not a difference in heart failure hospitalization, but it was really based on this, which is the number of pairs and greater than 15 points in KCCQ from baseline. 87% of these individuals had moderate or less TR at 30 days, so it was a fairly effective procedure compared to only 4.8% for the control group. Really, the take-home message here: tricuspid valve intervention, TEER, associated with improved quality of life at 1 year. No differences, though, in heart failure, hospitalization, or death. But ultimately, this is a very short follow-up, and longer term is really needed to assess the impact of heart failure hospitalizations, as well as the durability of intervention. It's not surprising that at 1 year we didn't see a difference in heart failure hospitalizations or death, but we can't say that there's any impact at this time besides just improved quality of life. Moving on to BIOVASC, and apologize again for going quickly. There are numerous studies with interventional cardiology, including complete and culprit trials, that demonstrated that there is benefit of complete revascularization and ST elevation MI, although extension to end-STEMI and other causes of ACS is not yet clear, as well as the optimal timing of these interventions. Should they happen at the time of the initial revascularization, or should they be staged to a later time? This was a multi-center prospective randomized non-inferiority trial looking at adults with ACS and multivessel disease, randomized to either immediate revascularization of non-culprit lesions versus staged intervention. Exclusion criteria included patients with a compromised CABG, cardiogenic shock, as well as chronic total occlusions. So like I said, the intervention was immediate complete revascularization compared to staged intervention, with an outcome of being a composite of all-cause mortality, myocardial infarction, unplanned ischemia-driven revascularization, or cerebrovascular accident at 1 year. Ultimately, they enrolled 1,525 patients. 764 were randomized to immediate complete revascularization, and 761 to staged intervention. The median age of these individuals is 65.5 years. They were predominantly male, 78%. 21% had diabetes. About 40% of them was in the setting of STEMI. 51% of them was in the setting of end-STEMI, and 8.3 for unstable angina. In terms of the results from this trial, we can see that the primary composite outcome occurred in significantly fewer for the immediate revascularization group as compared to the staged revascularization. It was not inferior, it was not superior, so there was no significant difference there between the two of them. It was the immediate revascularization was non-inferior to staged intervention, but it's primarily driven by increased myocardial infarction as well as unplanned ischemia-driven revascularization in the stage group. There's no difference in all-cause death and no difference in cerebrovascular accidents. The median time to myocardial infarction in the stage group was only 16 days, with 44% of them not related to stage procedure. So for the myocardial infarction, they graded as to whether or not it happened in between the initial revascularization and the planned stage procedure, or at the time of the stage procedure itself. Kind of key take-home messages from it. Immediate complete revascularization is non-inferior to stage procedure. A lot of times in the cath lab, when we see someone have a non-culprit vessel, we end up bringing them back for a staged procedure. At least from the initial BIOVASC study, it gives us confidence that you could do both of them at the same time, and you might be associated with lower rates of myocardial infarction at follow-up. Some of the reasons that they think that this is the case might be due to misjudgment of the culprit lesion in end-STEMI. We think that we're revascularizing the culprit lesion, but it's possible that we're actually revascularizing the non-culprit, or it could be the fact that there are multiple unstable plaques in a pro-inflammatory state, and doing complete revascularization at that time is associated with at least better outcomes. Additionally, there's a potential cost benefit. You're avoiding a second hospitalization, you're avoiding a second procedure, but ultimately there's a couple of downsides. One is that you're eliminating opportunities for a heart team discussion as to whether or not surgery would be better than a percutaneous approach. Additionally, you're having a longer procedure, increased dye load for patients who have underlying renal dysfunction. And also, depending on the time of day that these happening, you're having a much longer procedure. Operator fatigue is going to set in. Moving on to yellow 3. So this is one of our fantastic trials done here at Mount Sinai, done by Dr. Kinney in the cath lab. This is a single center, single arm study looking at patients presenting for PCI who had an additional non-culprit lesion that were non-obstructive and they're already treated with statin therapy with an LDL of greater than 80 for low to moderate statin therapy, greater than 60 for high statin therapy, or greater than 100 for patients with statin intolerance. And the kind of gist of the study is what is the impact of PCSK9 inhibitors on the fibrous cap as well as the lipid burden. We know that there's an entire field within cardiology dedicated to TICFAs, which are thin cap fibroatheromas, what we think are these unstable plaques that are likely related or likely responsible for ACS events. And we know in terms of plaque stabilization with statin therapy, but wanted to see from a intracoronary imaging approach what happens with PCSK9 inhibitors. And the outcome here was the change in the minimal fibrous cap thickness by OCT, as well as change in NIRS lipid core burden index greater than 4 millimeters. So these were patients who ended up being put on PCSK9 inhibitors for 2 weeks, every 2 weeks for 26 weeks, and then came back for repeat intracoronary imaging just to take a look at the non-culprit lesions. We can see here some of the baseline characteristics of these individuals, 66 years old, predominantly male, many with risk factors including hypertension, all of them having prior PCI. And most of them were already on high-intensity statins at the time of randomization or of inclusion. In terms of the results, we can see that unsurprisingly, with the addition of PCSK9 inhibitors, decreased total cholesterol and decreased LDL cholesterol after 26 weeks of intervention. But the real interesting part is what changes to these fibrous caps themselves. So we see that at baseline, these non-culprit lesions, the fibrous cap thickness was approximately 70 micrometers. With the addition of PCSK9 inhibitors, significant increases in fibrous cap thickness, as well as significant decrease in lipid core burden index, essentially saying that these plaques now are stabilized with the addition of PCSK9 inhibitors, reduction in TICFAs, and ideally reduction in future events from rupture of these unstable lesions. These are some of the additional data just looking at individuals for fibrous cap thickness. You can see kind of the trend over into the green, which is a fibrous cap thickness of greater than 84, no longer having that thin cap that's at risk for rupture. And this is some of the NIRS spectroscopy imaging, just showing kind of the amount of lipid burden at baseline, and then at follow-up, how much a reduction there is in the LCBI. There is some additional studies that are going on in terms of genomics. There are some individuals that were non-responders to PCSK9, and they're doing genomic analysis to see if they can better predict which individuals might have stabilization of their plaques with the addition of PCSK9 inhibitors. So kind of the key take-home message from Yellow 3 is provide some insight into the mechanism of plaque stabilization through PCSK9 inhibitors with increase in fibrous cap thickness and result in decrease in the prevalence of these TICFAs, these thin cap fibroatheromas. And further data, as I said, from genetic analysis will predict kind of the responsiveness to PCSK9 inhibitor therapy. 2 more interventional trials. Another one done here from Mount Sinai with Dr. Greg Stone, the COAPT 5-year outcomes. This is a multi-center randomized open label trial. As we all know, it enrolled individuals with heart failure with reduced ejection fraction with an EF of 20 to 50%, with moderate to severe or greater mitral regurgitation with NYHA class 2 or class 4 symptoms, despite optimal medical therapy, randomized to either continued optimal medical therapy or transcatheter mitral valve edge-to-edge repair plus OMT. For the 5-year outcomes, the primary outcome was all-cause hospitalizations for heart failure through 2 years, and there were additional significant secondary outcomes that we'll talk about. This is from the initial COAPT paper in NEJM, just looking at the patients that were initially enrolled. The mean age is 72.2 years, 36% of them are women. About a third of them had had prior CRT-D placement, 60% of them were ischemic, 40% of them were non-ischemic, with a mean left ventricular ejection fraction of around 31.3% and dilated to 6.2 centimeters. For our 5-year results, see that significant reductions maintained. The initial COAPT study was also a positive trial, but we can see that even at 5 years, hospitalizations for heart failure significantly decreased in the intervention arm compared to the control arm with a hazard ratio of 0.49. We also see reductions in all-cause hospitalizations with a hazard ratio of 0.75 and death from any cause with a hazard ratio of 0.72. That being said, we do see that these curves have begun to narrow. Looking at individuals who had not been hospitalized by 3 years going forward, we see that the hazard ratio now includes 1, as well as death from any cause. These curves have begun to narrow and no longer are they dividing. There's a couple of reasons that people think that this is the case. We'll talk a little bit about that in the take-home message, but at 5 years at least, we can say that mitral valve transcatheter edge-to-edge repair for secondary MR plus optimal medical therapy is still associated with decreased rates of heart failure, hospitalization, and all-cause death compared to continued optimal medical therapy. That being said, this is an incredibly sick population. Looking at individuals who had had either a heart failure hospitalization or died within 5 years, even those who were in the intervention arm, 72% of them are going to have a heart failure hospitalization or pass away in 5 years, or 91% of patients in the control arm. Some of the reasons that they think that these curves are no longer separating, but have begun to essentially run parallel with each other, is that there is a high degree of crossover from the control to the intervention arm. 45% of the control group has now crossed over to transcatheter edge-to-edge repairs. Mitral valve and mitral clip intervention has really taken off since the initial release of the COAPT trial. And last, finishing up with our last interventional cardiology trial, we'll talk about the TAVR low-risk 3-year outcomes. So this was a multinational prospective randomized clinical trial looking at patients with severe trileaflet aortic stenosis, now with low predicted risk of death from surgery. We know that the initial TAVR trials were done in individuals who were prohibitive risk for surgical repair, then extreme risk, moderate risk, and now we're moving into the low risk predicted risk of death from surgery. Intervention was the Medtronic core valve, which is our self-expanding transcatheter aortic valve replacement valve versus surgical aortic valve replacement with a 3-year outcome of composite of all-cause mortality or disabling stroke at 2 years. So just looking at the patients that were enrolled, the average age was 74, and we're going to talk about that in a second. 35% of them were female, and just highlighting especially that there is a discrepancy between what is considered to be low risk and what is considered to be young. I think it's very easy to think of low risk patients as young patients, but that's not who we're talking about here. We can see that this is from the most recent valvular guidelines from ACC AHA, that for individuals at an age life expectancy of around 65 to 80 years, it's a class 1 indication for both surgical or transcatheter aortic valve. But individuals who are young, less than 65 years old, it is just surgical aortic valve. We're not talking about TAVR in these individuals. So we should not think about the TAVR low risk study as looking at young individuals, but really patients that fit into this box here that are at lower risk that you might consider for surgery otherwise. We see that at 3 years, there's no significant difference in the rates of all-cause mortality or disabling stroke. We've got a hazard ratio of 0.7, but we do see that it ends up including no significant difference with a p-value of 0.051, so just missing significance. Mortality, though, at least numerically, is lower in the TAVR group, 6.3 compared to 8.3. The risk of stroke is numerically lower in the TAVR group, 2.3 versus 3.4. That being said, transcatheter aortic valve is not all sunshine and rainbows. There is a higher risk of pacemaker placement with transcatheter aortic valve, as we all know, 23% in this group versus 9%, which is statistically different, as well as differences in paravalvular leak of 20.3 versus 2.5%. At least for the primary outcome, there's no significant difference in all-cause mortality or disabling stroke at 3 years for low-risk individuals undergoing transcatheter as compared to surgical aortic valve replacement. Kind of the take-home message, though, is that I do think that longer-term follow-up is needed for complete interpretation. We expect that low-risk individuals are going to have increased lifespans compared to those evaluated in the earlier studies of extreme, severe, moderate risk. And there is a discrepancy, as I said, between this concept of low-risk individuals and young, and I would suggest severe caution applying these results to younger patients, as that's not really the group that we're talking about here. So that's kind of the 5 main interventional cardiology trials that were presented. Let's talk about the last 2, and there's 2 in each: risk factor modification and then vascular. Risk factor modification is a very hot topic right now, and there were two trials that came out that got a ton of press. One of them was the STOP-CA trial, and the other one was the CLEAR Outcomes trial. So STOP-CA, it's a multi-center randomized double-blind placebo-controlled trial looking at adults with lymphoma who were scheduled to be treated with anthracycline therapy, randomized to atorvastatin 40 milligrams versus placebo, with a primary outcome of the proportion who had a decline of left ventricular ejection fraction of greater than 10% to a value of less than 55%. Now, this is not comparing the EFs from one group to the EFs in the other group. This is just the proportion of patients in each group that had to decline in their ejection fraction. We'll talk about that why in a second. So a little bit of a background. So there is some retrospective data that suggests that statin therapy may be helpful to limit the impact of anthracyclines on the myocardium. But there was a recent RCT that did not demonstrate any difference in ejection fractions for patients receiving anthracycline therapy treated with statin therapy compared to placebo. Reminder, that is not the primary outcome in this trial. It's the proportion of patients that had a decrease in their VF. And just from the up-to-date article, we can see pretty clearly that at this anthracycline dose of around 300 and greater, the incidence of heart failure, which again is a clinical diagnosis, it's not EF drop, but it's signs and symptoms of congestion, really starts to take off around this 300 to 400 group, but decline in EF is already increasing the subclinical left ventricular systolic dysfunction. Looking at the patients themselves, and STOP-CA is not published yet. This is from their presentation from ACC. It's a 12-month follow-up, a cumulative median anthracycline dose of 300, which going back is important just based upon kind of what you would expect to see in the outcomes. 300, you may not expect to see much incidence of overt heart failure, but you should start to see declines in EF around there. For the primary outcome at 12 months, the EFs were not significantly different between each group. We started off with a statin randomized group of an EF of around 63%, which decreased to 58.8, and a placebo EF group of, again, around 63% that decreased to 57. But we'll see that the proportion of individuals that met the criteria for cardiac dysfunction, which again was a decrease in EF of 10% to a value of less than 55%, was statistically significantly greater in the placebo group compared to atorvastatin. So much less people had that drop in the statin arm compared to the placebo arm. That being said, the absolute EFs are not statistically different between the two groups. Looking at kind of subgroup analyses, we do see that it does seem to be a little bit more effective in females. It does seem to be a little bit more effective in individuals who are older. And unsurprisingly, the more anthracycline therapy you get, the more effective statin therapy seems to become, probably as a result of increased primary outcome just with a higher risk group. Kind of take-home message, it's well tolerated in patients who are receiving chemotherapy. It reduces the proportion of patients who develop left ventricular dysfunction, but it did not have an impact on the overall ejection fraction in the entire cohort. It was not powered to detect an impact on heart failure events. You need a much larger trial, and definitely would want to look specifically at those individuals receiving higher doses of anthracycline chemotherapy, just because you'd expect that that's where you're going to really start to see heart failure events take off. And I think the ultimate question is going to be, should statins be prescribed to all patients receiving anthracycline chemotherapy, or should we use anthracycline thresholds to determine who should be prescribed? Should this be really in that higher 300 and greater group? I think that story is still a little bit yet to be told. We'll talk about CLEAR. So CLEAR was a double-blind randomized placebo-controlled clinical trial looking at patients with primary or secondary prevention with an LDL of greater than 100 who were either unwilling or unable to take statin therapy. And this was by definition, either they had intolerance to 2 or more statins or had intolerance to one and were unwilling to take another. These individuals had to sign a fairly extensive statement saying that they recognize that statins are recommended for them to decrease the risk of death, but they are unwilling or unable to take them at this time. Intervention was bempedoic acid, 180 milligrams versus placebo, and we'll talk on the next slide about what bempedoic acid exactly is, with the outcome being a composite of death from cardiovascular causes, non-fatal MI, non-fatal stroke, or need for coronary revascularization. So what is bempedoic acid and why are we interested in it? So it's an ATP citrate lysase inhibitor. It's upstream of HMG-CoA reductase, which, as we all know, is the enzyme that statin therapy acts on. It decreases hepatic cholesterol synthesis, similar to the way that statin therapy does, but it's activated in the liver and not the peripheral tissues, which is thought to reduce adverse effects, myalgias, which tends to be the main reason that patients are unwilling or unable to continue with their statin therapy. This is a very large trial looking at nearly 14,000 patients with an average age of 65.5 years and an average LDL of around 140 at the time of enrollment, with a long duration of about 3.5 years. At the results, you can see that bempedoic acid compared to placebo is associated with a significant reduction in LDL cholesterol of 29, with about a 21% relative risk reduction at 6 months, and also reduction in inflammatory markers, CRP, compared to placebo. In terms of hard outcomes as well, it's a significantly reduced rate of the 4-component MACE that we talked about initially, which is driven primarily from reduced fatal or non-fatal MIs or decreased coronary revascularization. I'll highlight that there is no difference in all-cause mortality or fatal or non-fatal strokes in the bempedoic acid group as compared to the placebo group. There was no difference in the overall adverse events, although individuals in the bempedoic acid group did tend to have higher rates of gout and cholelithiasis in the intervention arm. This has received a lot of interest within the cardiology world. There's already advertisements, I'll tell you, downstairs in GP1 Center for their medication. It may be a reasonable alternative for patients who are unable or unwilling to take statin and that don't want to take injections that accompany PCSK9 inhibitor therapy. That being said, statins are likely to remain the standard of care, and we should still recommend them to ASCVD patients. I don't think that anyone is saying that you have a patient who comes in that you would normally recommend statin therapy for, that you should recommend this beforehand. It's really for these select patients that are either intolerant or unwilling to take statin therapy. The other point is that it's much more expensive than statins, many of which are now generic. I went online last night just for a good RX in the local community. Nexletol, which is bempedoic acid, for a 1-month supply is $388 after saving even 19%. Atorvastatin, 80 milligrams high dose is $9.48. So this is still a very expensive medication. There are other formulations that they're coming out with as well, combining bempedoic acid with Zetia. We'll see how much. I think that for those select patients that are unable or unwilling, I think it's a reasonable alternative, but I think statin therapy is still going to remain kind of the standard of care for most of our primary and secondary prevention patients. We'll go quickly through vascular, and then one other thing before I hand off the mic. So for vascular, there were 2 studies that we want to talk about. One of them is Freedom COVID, which was done here, and the next one is the Stellar trial. A disclaimer for Freedom COVID is that I was a co-author on it and helped serve on the adjudications committee. So this was a multi-center randomized 3-arm open label trial for adults who are hospitalized within 48 hours of COVID infection, not thought to require ICU admission within 24 hours, randomized to one of 3 arms, 2 therapeutic arms and 1 prophylactic arm, either prophylactic Lovenox, therapeutic Lovenox, or therapeutic Eliquis, while hospitalized, with a outcome of 30-day composite of all-cause mortality, requirement for ICU level of care, systemic thromboembolism, or ischemic stroke. Looking at these patients themselves, this is in preprint currently. It should ideally come out soon, but it's available on JACC at this time. And I should have said, but this was run by our Dr. Fuster here at Mount Sinai. We looked at 3,400 patients that were enrolled, which is slightly lower than what we were looking for. Initially, ideally, I believe that the initial enrollment cutoff was going to be 3,600 patients. 19 patients withdrawn, 35 patients ended up testing negative prior to being enrolled in one of the 2 arms. We had about 1,100 randomized to prophylactic Lovenox, around 1,100 to therapeutic Lovenox, and 1,100 to therapeutic Eliquis. Looking at the primary, median age was 53 years. They were predominantly male individuals. Looking at the primary outcome, so numerically, the primary outcome occurred less in the therapeutic compared to the prophylactic anticoagulation arm, although these results were not statistically significant. So going back again, so just our primary outcome was a composite of all-cause mortality, ICU level of care, thromboembolism, or ischemic stroke. So at least for the primary outcome, it was not statistically different between the 2 groups. That being said, if you looked just at all-cause mortality, which is a secondary outcome, and by design, you're really not supposed to evaluate secondary outcomes when your primary outcome is negative. It's supposed to be only hypothesis generating. All-cause mortality was statistically lower in the intervention arm as compared to the prophylactic arm, with a mortality rate in the intervention arm or the therapeutic arm of 4.9% compared to 7% within the prophylactic arm. There were significant differences within subgroup analyses. I'll just raise here just to geography itself. You can see that for the primary outcome itself, just within the United States, it was significantly better to be on therapeutic dose Lovenox or Eliquis as compared to prophylactic dose. In India, it was very, very different. There's a lot of reasons that we think that this happened, one of which is just the patients enrolled in India tended to be a lot younger and a lot healthier compared to the patients that ended up being hospitalized within the United States. There are other subgroup analyses showing that therapeutic dose might actually be beneficial for individuals with X-ray findings consistent with ARDS, but it's a secondary outcome. Ultimately, the take-home message, the primary outcome was not met, but some key secondary outcomes for mortality as well as intubation, which I didn't show, were significantly improved for those receiving therapeutic dose anticoagulation. They're hypothesis generating, and there were significant differences based upon the region of enrollment and radiographic findings, as well as the time course as to which enrollment happened. I think we're all fairly aware and have kind of come to recognize in our own day-to-day care for patients that the variants that we're seeing now behave very differently from the variants that we saw early on in the COVID pandemic. And the outcomes were much lower now compared to earlier enrolled patients. And whether or not that decreased amount of the primary outcome occurring just because of the variants changing our ability to recognize differences in the two groups, I think is a very valid question to bring up. And last, but certainly not least, was the STELLAR trial. STELLAR, I think most people who have talked about ACC have said that STELLAR is going to be the most impactful trial that was presented there. And I think its name really does do it justice. So we'll spend a little bit of time on STELLAR before getting away from randomized clinical trials. So what was the STELLAR trial? This is a multi-center, double-blind, phase 3 randomized clinical trial for patients with group 1 pulmonary arterial hypertension, functional class 2 or 3. So not like the most severe patients and not the least severe patients, but class 2 or 3 who are receiving stable doses of PAH therapies for the past 90 days, randomized in a 1-to-1-to-1 to either placebo, 0.3 mg per kg sotatercept, or 0.7, apologize for the misspelling, or 0.7 mg per kg sotatercept. The primary outcome being the change in PVR at 24 weeks, and a secondary outcome including change in 6-minute walk test, along with a myriad of others, including NT-proBNP and kind of signs of wellness and well-being. So background, what is sotatercept? So research within pulmonary hypertension demonstrates that part of the etiology of the disease is just increased proliferation within the pulmonary vasculature. Sotatercept is a first-in-class fusion protein consisting of the Fc domain of IgG linked to the extracellular domain of ACTR2A, acts as a ligand trap for TGF-beta superfamily members, and at the end of the day, shifts the balance towards anti-proliferation and pro-apoptotic signaling. This is taken directly from the New England Journal article. You see that typically we have these pro-proliferative activins and GDFs that end up being pro-proliferative and block anti-proliferative effects. Sotatercept is a trap for these molecules, which shifts the balance towards anti-proliferative signaling. The results themselves. The mean age of these individuals is 47.9 years. Most of them had already been diagnosed for 8.8 years at this time. At baseline, 61.3% of them were receiving triple therapy of PAH medications. About 40% of them were on chronic prostacyclin infusions. The baseline PVR in DINES is 778, which is just below 10 for PVR and Woods units that we typically use on our right heart caths here, and the mean PA pressure was 52.4 millimeters of mercury. At 24 months, significant reductions in PVR with about a decrease of what it would be about 2 Woods units, DINES of 162, and just the low dose sotatercept 255, even greater at higher dose. The overall is about just under 3 Woods units. Significant improvement in 6-minute walk test. Even the placebo group increased an average of 28.7 meters, but it's up to 53.5 in the sotatercept group. Significant reductions in NT-proBNP and functional class. At the end of the day, speaking to people within the pulmonary hypertension world, a lot of them think that this is going to completely change the landscape and is a new class of medications within the PAH upon which all future trials should at least have a basis of sotatercept therapy on top of other agents. Take-home message, it improved PVR, it improved 6-minute walk test, it improves NT-proBNP with individuals with group 1 PAH. There were some increases And side effects, notably epistaxis, telangiectasias, and dizziness. This does result in angiogenesis, and that's some of the etiology of the epistaxis and the telangiectasias. That being said, it's incredibly well tolerated with 98.4% treatment adherence in the sotatercept group. Stellar, I think everyone has said, has really been the trial that's really going to change the game for things that came out with ACC. In my last 2 minutes, I've been asked to present some of the research that I presented at ACC before handing off the mic to Adam and Sophia. So this was research that I did here along with Dr. Goodwani, Dr. Tommy, Dr. Liebner, and the group up at the Brigham, the TIMI group, looking specifically at heart failure related, and Maria Ronquillo, who's in the room as well. Differences in heart failure related cardiogenic shock between ischemic and non-ischemic cardiomyopathy from the CCCTN registry. So what is this registry itself? It's a registry of CICUs across North America that's coordinated by the TIMI group. We know that for patients who are admitted to CICUs for cardiogenic shock, the predominant etiology is going to be heart failure related, although the predominant amount of research tends to be into acute myocardial infarction cardiogenic shock. What we wanted to look at specifically is heart failure related cardiogenic shock, stratifying these patients into either ischemic or non-ischemic cardiomyopathies, looking at things like baseline characteristic differences, treatments, outcomes, and hemodynamic parameters for admissions. Ultimately, we had 1,844 patients with heart failure related cardiogenic shock. 692 of them were deemed to be ischemic by the primary center that coordinated information, and 1,152 patients in the non-ischemic group. At baseline, unsurprisingly, there are significant differences between the ischemic and non-ischemic cardiomyopathy group. Patients in the ischemic cardiomyopathy group tend to be older, more likely to be male, and more likely to have higher rates of comorbidities that we'd expect: hypertension, diabetes, underlying CKD, although the length of time from heart failure is not different. Most of these patients had chronic heart failure, and this was not an acute process. In terms of treatments and hemodynamics, there were significant differences between the two groups. Patients with non-ischemics were more likely to have Swan-Ganz catheters and invasive hemodynamic monitoring at the time of their hospitalization. Patients with ischemics, unsurprisingly, more likely to undergo invasive coronary angiography, also more likely to require mechanical ventilatory support, and no differences in renal replacement therapy between the two groups, despite the fact that ischemics had higher rates of CKD at baseline. When we look at kind of their invasive hemodynamic parameters, more likely to have right ventricular and biventricular dysfunction for non-ischemic cardiomyopathy, as well as slightly lower cardiac output and cardiac indices for a non-ischemic group. Patients with left ischemic cardiomyopathy more likely to have predominantly univentricular left ventricular dysfunction. Looking at outcomes themselves, even after adjustment for baseline differences, including age, sex, CKD, diabetes, and underlying SOFA score, patients with ischemic cardiomyopathy had a 1.54 times greater risk of in-hospital mortality compared to non-ischemic cardiomyopathy. Patients with non-ischemics were more likely to go on to heart transplant than those with ischemic cardiomyopathy. Ultimately, it's impossible to tell from a registry analysis why this is. Some predominant theories are that patients with ischemic cardiomyopathy are more sensitive to hemodynamic perturbations than those with non-ischemic and end up in this kind of ischemic death spiral. As for why patients with non-ischemic are more likely to go into heart transplant compared to ischemic, possibly that individuals with ischemic cardiomyopathy just have higher rates of comorbidities, which would deem them less likely to benefit from transplantation. And thank you very much. At this time, I will pass the mic over to Adam, who's one of our second-year medical students, as Sophia Golick, who's one of our third-year internal medicine residents, so I believe we're on the line to present their research. I'm happy to click through slides, Adam, if you'd like to tell me when to advance.
Great. Thanks for the introduction, Dr. Feynman. Is my audio coming through all right?
I can hear you.
Great. You can advance to the next slide, please. And thank you everyone for the opportunity to briefly present our ACC abstract, the surprise question and EHR initiative to facilitate primary palliative care in the CICU, which we developed under the mentorship and supervision of Drs. Goodwani and Ronquillo. Next slide, please. In 2014, the Choosing Wisely ICU initiative recommended eliciting and documenting patient care preferences in order to provide goal-concordant care and promote shared decision-making. But how best to actualize this recommendation in a consistent and timely fashion is not clear. And this was the challenge that the CICU took on. So emanating from the Choosing Wisely recommendation, using plan, do, study, act quality improvement methodology, a multidisciplinary team of attendings, informaticists, residents, ancillary care team members, and medical students developed an EHR-based workflow to firstly identify patients at high risk of mortality, and secondly, to encourage appropriate and timely follow-up actions. Next slide, please. The intervention, inspired by the SIRS alert system, leverages a new workflow column built into the Epic patient list dashboard that uses a simple validated tool for mortality prediction, the surprise question, and a red, orange, green icon alert system. The way this works is the surprise question column alerts red on all CICU admissions with the following. Would you be surprised if this patient died within the next 6 months? If the clinician selects yes, indicating that the patient is relatively stable and at low risk of mortality, no further action is required beyond standard care. The red alert is automatically cleared and replaced with a green icon. If the clinician selects no, indicating that the patient is at high risk of mortality, a non-interruptive orange alert is activated, indicating a goals of care conversation is required. To clear the orange alert, the clinician must complete and document a family meeting using a smart phrase template. Once complete, the orange alert is cleared and replaced by a green icon. Our intervention went live in Epic in April of 2022, and for the purposes of ACC, we set out to study differences in the clinical course of patients flagged by the surprise question as compared to the rest of the CICU population, and also to measure implementation outcomes. We accomplished this via an EHR data query. Over to you, Sophia.
Go ahead and advance the next slide. And thank you so much, Jason. That was a fantastic summary. So to talk about our results, within our study period between April and July 2022, there were 523 admissions to the CCU. Of those, 456, so 87%, had the SQ answered, which suggests a high degree of utilization of our Epic workflow. Of the patients with the SQ answered, 78% had the answer of SQ equals yes, meaning that the clinicians would be surprised if the patient passed away in the next 6 months. 20% had an SQ of no. We retroactively studied the outcomes of the patients and found that patients for whom clinicians would not be surprised if they passed away did end up having a higher likelihood of longer length of stay, more CCU interventions such as renal replacement therapy and intubation, and higher mortality. This confirms that clinicians are able to identify these high-risk patients effectively. We then confirmed the utility of the workflow for palliative care intervention by tracking the time to completion of the SQ answer and then the completion of the goals of care note. The SQ answer was typically completed within the first 24 hours of admission, and the goals of care note was typically completed within the first 48 hours. These data show that this is an effective workflow to identify high-risk patients in an ICU setting and to target early palliative care intervention. Thank you so much for your time.
Thank you so much, Jason, for this amazing whirlwind review of all the important work done at ACC, especially the productivity and the quality of work coming from Mount Sinai. Some very important ones. Didn't have enough time to explain the background, such as the background behind revascularizing one or more vessels, the background behind the use of bempedoic acid. But one of the most promising is the Stellar, which is a drug called sotatercept, which is essentially an anti-proliferative drug. There's a very interesting article on the mechanism of action, but this is, you're going to see it, at a drugstore, coming to a drugstore near you shortly. This is a phase 3, so the next step would be to go to the FDA, and everybody in pulmonary hypertension is extremely excited. Remember, the population was already 100% of patients were on medical therapy for pulmonary hypertension, and the majority were on triple therapy, and despite that, they had class 3, class 4 symptoms. So there's a real role to be played over here for sotatercept. And I want to thank our medical student and our second year at that time, now third year medical resident. I think the first time in Grand Rounds that a tag team of med student and medical resident have presented some very important work from the CICU, which was appreciated in ACC. And there were some very interesting AI type questions that came from especially a cohort at Carnegie Mellon University. Open to questions, please. I know we don't have too much time, but certainly happy to take one or two questions. Please raise your hands. And I think Evan is handling questions.
There doesn't seem to be any question. Oh, Norma Braun has a question. I'm going to let her ask. Norma, please feel free to ask.
Anyway, it's a wonderful presentation. I really, really enjoyed it. But especially the issue is how, with the palliative end of life care in the CCU, how was the conversation? Was there an algorithm for that? And how did the families, patients respond to it in terms of understanding and outcome?
Okay, that's a great question. And we struggled with that a lot because each scenario is different. And therefore, initially, so we used the acronym of SPIKE, which is a pretty standard palliative care intervention on delivering bad news, and it is fairly open-ended. And the point here was not to make sure that everybody was DNR, but the point was to make sure that these people who admittedly, demonstratedly had worse mortality, worse length of stay, and worse or increased number of CICU interventions, that we were talking to their families, that we were eliciting goals of care. We are looking deeper into what was achieved after this. But the most important thing coming out of this was that this was a fairly predictive tool, the surprise question, which kind of confirms what has been thought of previously in palliative care. But as far as I know, first time used in the ICU in this form, which is that how surprised would you be if it was 6 months? People have used 12 months, 24 months, depending on the setting, that is in hospital versus outpatient and so on. But we use this in the ICU having a 6-month cutoff, not based on any evidence, but just to see, how predictive this would be. And we were happy to see that. So that's really the only thing that we can conclude from here. And the second thing we can conclude is that these people, a majority of these people got early conversations. In other words, hey, your loved one is sick, starting from there and then going down the road. So if there are no other questions, at 3 minutes after 2 o'clock, we will close this session. And I want to thank Jason for doing just a phenomenal job. You can see that he has a very promising career ahead. He did a wonderful job with the ischemic versus non-ischemic cardiomyopathy, which we always had a question that, what's going to happen. So thank you very much, and see you next week. And hopefully next week we will not have these technical issues.